So if we start with the first one, knowledge. The knowledge is basically as simple as the FRCS. That's the knowledge that you need to get as a neurosurgeon in the UK. Um, Again, I'm not going to discuss in much detail. I will just give some hints about that. Again, if you have any questions before we jump to the next section, please let me know and we can answer those questions. But the bottom line for your knowledge is basically FRCS, and that basically sets the bar for you becoming a consultant neurosurgeon in the UK. That's the amount of knowledge that they would expect you to know as a first day consultant. So whenever you read or you study or read in neurosurgery, always keep in mind how am I going to deal with this as a first day consultant? What's really important as you study for neurosurgery is to know something about everything rather than knowing everything about something. And I say that because I have seen other people, like trainees who, it's their first year of training and basically they are going through 7 series of Michael Lawton or Spetzler and reading all the very, complex books without reading the basic things of neurosurgery. So, you can develop some subspecialty interest as early as possible, or as early as you want, but I would suggest that try to know something about everything. So it's not wise that you know so much details about how to operate or about AVM, but you know nothing about functional neurosurgery, for example. So that's really important to know. I've done the same mistake myself early on my training, and I was kind of deep dive into the neurovascular, but I didn't pay attention to other things, and I paid the price later on. So please kind of try to cover all aspects of your knowledge as much as you can. And if you haven't passed the FRCS, you will be surprised that the level of knowledge that you need for every aspect of neurosurgery is not a lot. It's easy for me to say that now, given I passed the FRCS, but you'll be surprised that it's kind of the outer shell of the knowledge that you need, rather than diving deep into the details of that aspect. And you have to set up a study pace for yourself. So you have to study regularly. I know it's difficult with your job. You work days and nights and everything, but try to have like a study. To try to study every week. Don't pass a week without studying. Just some resources which I found useful during my training. The handbook. I don't like it much, to be honest, but again, it's one of the biggest books for neurosurgery. This is the Oxford textbook for neurological surgery. This book is really good because it covers the topics in a kind of plain language, and it has a lot of evidence and kind of discussion. So I think if I would choose one as a knowledge source for myself, I would probably choose the Oxford textbook. This book is called Neurosurgical Review with this guy Vasilius Zeris. I don't think a lot of people know about it, but this book is basically putting most of the neurosurgical knowledge in tables. Some people don't like it; they like to read more text. But for me, that was really useful because you have a visual image of a table that basically covers everything in neurosurgery in tables. So that's a really useful resource. In terms of other resources which are useful for the exams, and you don't have to read those like just before the exam. You can read them as early as possible, because that basically gives you the flavor of how you think from a clinical perspective about the knowledge that you read. So basically, this one is from the UK. Vivian Elwell, the Essential Guide for Oral and Clinical Neurosurgical Examination. You have the Goodman Oral Board Review and the FRCS Viva casebook by Anderson. And those books, I think the case books are really useful because, again, as I will talk about it later on, in the UK they focus a lot about the clinical aspect of your knowledge, and you will come across that in your exam. So always try to have a clinical perspective of what you read as much as you can, and the best way to do that is by reading through case books. There are different other case books like Rami Nader and other books, but whatever you want. There is another book by I don't remember it now, but I'll remember it as we go. Other resources, Neurosurgical Atlas, it used to be free. Now it's for a fee. So unfortunately, you have to pay for it if, unless you have some institutional access, but it's a wonderful resource, to be honest. Radiopedia also is really good because it can give you kind of structured cover of specific topics and helpful also for the radiological aspect of our job. So the how to study, it might sound like a simple thing to do, and you will probably study like a lot, but most of us, I think, in this call are basically, or in this session, it came from international medical graduate kind of background. And the difference is that we studied medicine in a different way or we were raised in a different environment than the UK. And I see this with my kids. They study or they read or they criticize things in a different way than myself. So those are the four things that I find really useful when you study. Number one is basically to question everything, explain it to your mom, think in a clinical way, and case logbooks. And I will explain what I mean by that. Question everything is basically ask the whys and whats and everything. So if you read or you know about an approach, ask why this approach, not a different one. Let's say, for example, if you have a colloid cyst and someone says it's a transcortical approach, then the question is why this one is a transcortical approach, not an endoscopic one, and what's the rationale for that? Don't just take things for granted or because the consultant said so. Go and read about it and get your rationale about everything. And that basically will help you in your future life as a consultant, and will help you in your exam and your knowledge, because this is how you can justify whatever you want to do. Why this decision? Why did you decide to operate or not to operate? Why did you decide to go conservative for this one, not the other one? And that's what are the other options available for this patient. The other one is explain it to your mom or to your grandmom or a kid, whatever. But when I was doing my master in Oxford, my professor always asked me. I kept talking about my project, and he didn't understand anything. And he said, just talk to me in a plain language, explain it as you are explaining it to your mother, who's not a medical person. And that basically the teaching or the learning pyramid as you see it. If you haven't seen that before, it basically says that the top of the kind of the least effective way of learning is basically a lecture, and the best way where you get the most benefit out of learning is by teaching others, which is 90%. So if you read something or study or keep repeating it or discuss it with something or even doing it, you will not learn as efficient as teaching others. So it might be as easy as reading about a topic and go and teach your FY2s about it, or read about a topic or talk to your wife or your kids about it. So that's really useful way of learning. And I found that you can even talk to yourself in the mirror and say I'm explaining this to someone who is non-medical. And when you start doing this, you will find that your mind and your brain is working in a different way. The third aspect or the fourth aspect is basically thinking in a clinical way. And that's something I keep telling the guys going for the exam about it, which are, what are the patient's questions? And if you think about it, in each condition that you treat, always try to think about the patient's questions. Like, the patient is asking, when is that pain going to go away? How's the pain, when would I expect to get better or get back to work after, lumbar discectomy? Or a patient coming with a prolactinoma and she asks about pregnancy. And if you think from a patient's perspective, you can come up with a lot of questions that will help you study, and basically you will read about answering those questions. And I think that nearly 90% of the knowledge that we have are patients driven. So we are treating patients, and those are the questions that we need to know in a clinical environment. The other thing to think about it as you study is basically what if. What if means what would happen if what would happen if X happens. What I mean by this is, what happens if the patient woke up with contralateral hemibody loss of sensation, pain, and temperature in a posterior fossa tumor? And thinking in that second order, that helps you to understand the anatomy, for example, in a different way. So in the exam or in reality, no one is going to ask you what's a lateral medullary syndrome or what's causing a lateral medullary syndrome. And you can say it's a pica problem. But they would ask you about a patient who had a posterior fossa surgery and woke up with a specific, problem, and then you need to figure out what's the affected vascular territory or affected vessel in that case. So always study the neuroanatomy or anything that you read from a clinical perspective. And I hope that I made it clear. So if you have any questions, please let me know. Before we jump to the technical part, anyone have any questions about the exam, about the first part that we spoke about? All right. Um, if you have any question, please kind of speak up because I can't see the full names or in front of me.
Mohammed, I wouldn't say a question, but I would second the same point you've been talking about, the way you speak to the patients and explaining everything. This was an essential part of the exam. And I remember when I sat for the exam, they keep asking you about explain to the patient, go through this with the patient, show me how to communicate these information and deliver these information to the patient. This is an essential part of the exam to communicate with the patient in his language and deliver the information in this way, and they assess your way of communication and your way of response to the questions he would ask you, and to the aspects he would inquire about during the exam. And just seconding your point, it's really important point. Thanks.
Yeah, yeah. Thanks, Hazim. Yeah. And I think, as I said, and as Hazim is saying, is you will find it much easier when you study this way, and you will, as you think from a patient's perspective, you will always come up with loads of questions yourself that you never thought about it before, and that will trigger you to go and read about it. And basically, this is how you collect your knowledge. So we'll move to the technical part. The technical part, as you all know, you need the 1,200 cases for your training in the 8 years or 6 years of training. If we take out the 2 years of the ST1 and ST2, but basically for us as non-trainees, as you submit your Cesr application, you need 6 years for the 1,200 cases. So you need to get the numbers done. But it's really important that as you come to the UK, you have to think, okay, who am I? Are you someone who came to the UK with a lot of experience before, which might be a lot of us, who kind of practice in your own country, your home country, and you came to the UK with a lot of experience, and that will set the bar differently from what you want to achieve here in the UK. Or you're just coming and you have never, used a scalpel before, and you want to start your career. So you have to be clear about your objectives as you start in the UK. And as you probably have seen, there's a lot of people in the UK who don't have, the skill that you would expect. And what I mean by this is some of us might come to the UK with an assumption that everyone is like Michael Lowton or Spetzler or, big names, but everyone is practicing neurosurgery to an average level. And we have people, some of us might have a talent, and some of us might have a skill, and some people would combine both. And that's what's really important. And when I say that is because it's really important that you keep repeating the same thing again and again and again, and that's how you develop the skill. So even if you're not talented in terms of your hand skills, you still can become skilled as a neurosurgeon. But how do you do that? You do that by repeating the same thing again and again and again, 10,000 times, and you will get better. So don't get frustrated if you see yourself, you think that you don't have the talent, but you probably you will find some people who might have the talent, but they didn't persist and they didn't practice as you, and they wouldn't be as good as someone who is skillful, basically. What's really important is to put milestones for yourself, and the milestones are basically you have to think, okay, what I want to achieve in the next 1 or 2 years' time. If you're starting, okay, so when I'm going to achieve independence in X operations, how am I going to be when I'm going to be independent doing a lumbar discectomy, for example, or independent doing a craniotomy, or independent being on call on myself without calling a consultant or a senior colleague to help me. And that's really important to do, because by setting those milestones, you will define what are the next steps in your career. Some of those steps, which I will mention later, might be moving from the unit that you are in at the moment, because this unit is not satisfying your needs, basically. You might be in a small unit that you don't have specialist operations, and you might be in a large unit that you don't have the opportunity. So that's the importance of setting those milestones for yourself. And you can basically guide yourself through that by the training pathway for the trainees, basically, which is dividing this into 2 stages or 3 stages, as I remember. And one of the most important things is that you reflect a lot. The reflection might sound like, a bit cheesy, or something that a lot of us think about it in a way that you have to put on ISCP or things like this. But reflection is really important for your life. You have to reflect and think, okay, what I have done right, what have I done wrong, and how can I improve? And you need to ask yourself this question, ideally daily, on a daily basis, if you can't, at least on weekly basis or monthly basis. And from a technical perspective, you need to criticize yourself of what you are achieving every week. And you need to ask your colleagues, ask your friends, ask your seniors, ask your mentors, how am I doing and how am I progressing? And that's really important. Then I put this point about keep moving, because a lot of us, or most of us, would probably work in a unit and you get comfortable and then you stay in the unit for ages. And I have seen this example multiple times. Unfortunately, the reality says that you have to move, out of through multiple units. Some people have been lucky to stay in the same unit, but those are kind of rare examples. And not all of the units in the UK would support you to stay for long. If they support you to stay for 2-3 years, that's fine, 4 years, but it might be difficult to finish the whole thing within a same unit. There might be some examples of that, but I can tell you that probably the reality would mean that you have to move. But what's more important is when to move. And when to move means that you make that decision yourself. And I think about this in, can someone win progress? And what I mean by this is, it's just a mnemonic, basically. I would move from a unit if, number one, I don't have any career progression, which means that I'm not getting any support from the team. I'm not getting any progression in terms of my technical skills or educational knowledge. And that can happen a lot. There are some units that you can stay for a year or two and you're not progressing by any means in terms of your technical skills. So if you are in that place, please move. Don't get used to the comfort zone and not moving between different places. The second thing is support. If you're not working in an environment or in a place that you're not supported, basically means that you're not supported by your consultants, you're not supported by your colleagues, you're not supported by having educational and clinical supervisors, then always move. That will be my second kind of red alarm to move from this unit. And the third one is work environment. You can work in a very small unit, and that I always say that to people coming, first time in the UK. You might work in a very, very small unit, which have like 3 or 4 consultants, and you might enjoy your time way better than working in a state-of-art center in which have like 20, 25 consultants. And I have been in that situation myself. I enjoyed my time in a smaller units much better than bigger units. So if you don't have like a friendly working environment and you don't enjoy working, please move. the last point is perception. And what I mean by this is whenever you go to a unit, people will perceive you or will look at you in a specific way. And that first impression, unfortunately, always lasts for long. So when I came to the UK and I worked in Queen Square for a year, probably they have seen the worst version of myself because that was my first job. And I didn't know even how to talk to consultants, or even my English, was not great. So probably those people will always have the same impression about myself as being, like someone who knows nothing. And unfortunately, to change that perception might be difficult. So if you are in a place that you don't feel that people are changing their opinion about yourself or changing their perception about you, then please move. Don't stay in a place and keep complaining that they see you in a way that you are still junior, and they are not giving you the opportunity to do more complex things or bigger things. That I think that's probably your fault rather than someone else's fault, because that's your step. Next step should be to move out of this unit. And I know tens of examples of people that have had multiple situations that they had to move out of their units. And I know people who are still in the same place, 10 years down the line. And people might complain about this. But as I said earlier, the reality is that you probably will need to move from between different units. All right, so that's the end of this part.